Good evening, everybody. We'd like to see some hands up if you can hear and see us. So welcome very much. Welcome to all of you, okay, at the Suitcase Club for the 1st of August, where the wind started blowing as it should today. I'm just quickly going to run us through why we've got a Suitcase Club again. I'm just seeing why. There you are, okay. Right, so we're going to talk about when Guillain bars you from getting to your destination. And I'm just quickly going to give a little bit of background on the actual case, on how he ended up with Dr. Gengan. We doing this from the fire station Rosebank, from the clinic, the Travel Doctor Clinic here. And I'm going to do a quick reminder, because we haven't done it for a while, about what is the Suitcase Club all about. So Johannesburg is a springboard for travel, for work into Africa and many other things as well. We've got many returning travelers, of which some are ill. There's no central referral center for ill-returned travelers in South Africa, or for that matter in Joburg. And so we suffer from a lack of surveillance. And Prof. John Freen just walked in and said, I've got a lekker case for you for GeoSentinel, and we're going to grab it from him just now. So GeoSentinel is a joint venture between the International Society of Travel Medicine and the CDC in Atlanta, USA. That's the country that's somewhere between the old man and the other old man. And it consists of a global network of travel health centers that reports back on ill-returned travelers. The idea being that travelers are sentinels to disease outbreaks in different parts of the world. It provides important epidemiological data to travel or public health practitioners and researchers globally. And so our clinic in Joburg is GeoSentinel Johannesburg. My co-director is Dr. Prof. Lucille Bloomberg, who's probably somewhere on the online. And then we've also got a GeoSentinel center in Cape Town, and Dr. Mauro Sayo runs one in Nairobi in Kenya, and that's the only 3 in Africa. So we also have associates. So anybody who's interested but doesn't see enough travelers at any one time is welcome to submit cases, and I'm going to show you in a moment. So that's just the GeoSentinel website. You're welcome to go and have a look there. Just Google GeoSentinel and they'll come up. You'll get an idea about the work they do. And if you've got any interesting cases, and we're interested in them in the acute phase when it happens, please send us an email to geos@travel.corp.com or give us a ring, and we will put that into the GeoSentinel database. But the GeoSentinel network is also extremely useful when it comes to if you've got a weird and wonderful case and you're wondering what it might be. Is this a dengue? Is this a chikungunya or a whatever, which is sort of on the map worldwide because of global warming? Then they're the people to contact, and you can contact them via us. A quick punt just for special vaccines. We've had the Shingrix killed shingles vaccine available for quite some time now, about a year, if I remember correctly, maybe longer. We used to make it available as a Section 21 vaccine for immune-suppressed people. But since we started doing that, Zostavax, which was the live vaccine, has been withdrawn from the market globally. So this is the only vaccine available now for the prevention of herpes zoster. But it's not registered in South Africa yet, so we still bring it in as a Section 21 drug. It's horrendously expensive, but if you've got immune-suppressed patients, somebody that might have had an organ transplant, you can contact us and we can make it available. And then the other thing that we sadly have to make available as Section 21 is mefloquine for pregnant women traveling to high-risk malaria areas, because there's no mefloquine that is registered and available on the shelves right now. And the other one is atovaquone proguanil, the pediatric formulation, which we're also bringing in as a Section 21, and you can go to the website there and pick it up. And then I'm going to start with the case, having done the commercials. So we have a nice case study of a 51-year-old male. In fact, he's 59. I checked it up since I did that in. He's from Fiji, and we'll show you a map of the world shortly for those that don't know where Fiji is. It's not next to the Boksburg Lake. This gentleman is a security supervisor. In fact, we've got the health and safety manager here this evening, and he explained to me he's the guy that looks through a small glass window when they pour the gold to make sure that nobody pours gold into their boots or puts nuggets into their hems. So he's a senior guy in that respect. And he works on a gold mine in Mali. And the mine itself is about an hour and a half charter flight from the capital city of Bamako. And that's just important in terms of what happened to him in the end. So on Thursday, the 27th of June, Mr. Broomberg phoned at about 11:54 and said, we've got a patient that flew in from the Philippines on Ethiopian Airlines on Tuesday, the 25th of June. He collapsed on the flight and was taken off by ambulance to the Pasteur Clinic, and he cannot move his arms and legs. Now, everybody already knows what the diagnosis is, but it was a reasonable guess. So I started off with, if it's his first visit to Mali and he's come all the way from Fiji, it may be that he's having a mental breakdown, and now that he realizes how far he is from home, and this is all hysterical. And the other thing that did spring to mind was, I'm quite chuffed with myself to say, was Guillain-Barré. So that's just his route. So I'm not dead sure about his exact route from Fiji, but by the time he reached Dubai, he was feeling slightly unwell, but he got on the next flight, which is about a 2-hour flight to Addis Ababa. And in Addis Ababa, he felt unwell enough to call the medics to come and see him. And they did a pulse and a blood pressure, basically vital signs, and a blood sugar, and said, no, sir, you're fine. You can get on your next flight. So he boarded an Ethiopian Airways flight to Bamako, and he was accompanied from there by one of his colleagues that could fill us in a little bit. So immediately after takeoff, or shortly after takeoff, he became so weak that he couldn't get up out of his chair. And by the time he got to Bamako, he was taken off in a wheelchair, and he was taken by ambulance to the Clinic Pasteur that I mentioned. To our knowledge, because he's not been able to communicate properly, but to our knowledge, he was absolutely fit when he left Fiji the day before. It's approximately a 35-hour travel if you travel from Fiji to West Africa. So he went to the Clinic Pasteur. Now, we only found out about it 2 days after he'd been admitted. And the detail we got then was that he was on a medical oxygen face mask. His vitals were stable, but he had only about 1 out of 5 strength in his arms and legs. Now, we do pre-deployment medicals on all the expatriates for companies that are contracted to us. And so we could go look up his medical that he had in April this year. And on the annual medical, he was a 59-year-old male. He was considered to be fit for duty. And the only thing that was abnormal, apart from the fact that he's slightly overweight, but that's your average mine worker, is that he had a very, very slightly raised eosinophil count. And I just put it in here. I don't think it's significant. We would probably repeat it, but I thought maybe Prof. Freen is going to say, oh, yes, but but there was absolutely nothing else. And then there was one other critical question that I immediately wanted to know from my staff, and that was, did he have any vaccines? And we're happy to say that he didn't have any vaccines in April. We've got his vaccine record. He had a number of vaccines in 2021, but Guillain-Barré is not, to my knowledge, we'll leave that to Dr. Gengan, associated with getting vaccines a long time ahead of time. So there was nothing like that, and there's nothing, as far as we know, either of recent flu-like illness or a gastrointestinal disease. And I think, okay, so it took us another 2 days. So he arrived on the Tuesday morning. We heard about it on the Thursday. It took us 24 hours to get a report from the Pasteur Clinic. They were not prepared to just commit on email and basically say, the guy has got X, but they sent us a very comprehensive report the next day. And in the middle, on the second page, they underlined the diagnostic retenue, it's in French, is that they consider it to be a Guillain-Barré syndrome. And if you look in the fine print at the bottom, they actually recommended that we medevac the guy, which is great because they do have an intensive care unit. And sometimes hospitals in those situations tend to say, we can take care of the guy and we're happy to keep him here. But they actually recommended that he gets medevaced. So we then contacted his insurance, which is UK based, said, we've got this guy, presumably he's got Guillain-Barré syndrome and we want to medevac him. And the note on the right-hand side there is just that came from Mr. Broomberg, that got an update from International SAS in London a day or two later. But basically, it took from Friday to Sunday afternoon, 4 o'clock, for us to be sure that there was a commitment from the insurance company and that they'd put an air ambulance in place to say that they would medevac the guy. And then the next day, this is a photo taken by the mine doctor that by now had gone to Bamako to see the patient, saying the patient's in the back of the ambulance and they about to get onto the air ambulance. And you can see his route on the right-hand side there. So the air ambulance had to leave Johannesburg the day before. The crew overnighted in Accra, then flew into Bamako, picked the patient up, did a refueling stop in Sao Tome, and then came all the way through to Joburg, where he arrived on the Monday morning. I really just put this in to say that basically, if we think about it, the onset of illness was 7 days before the actual medevac. This is just a wake-up call for people who think, well, West Africa is just 8 hours flying time away. If somebody gets sick, we'll just medevac them quickly. The helicopter will go and fetch them. It takes 7 days for the helicopter to get there and get back, and that's the reality. And that's one of the reasons why we try and screen people before they go to remote areas. The point I made a little bit earlier that Bamako is an hour and a half by charter away from the mine. If the guy deteriorated slower and actually went to the mine, we might have had an even bigger problem to get him back into Bamako, to get him admitted, and to get him medevaced. So that's my story. And now I'm going to hand over to Dr. Kerena Gengan, who's the treating neurologist at the Sunninghill Hospital, who's going to come and do an update for us, not on some exotic infectious disease, but on Guillain-Barré that has got a link with infectious disease. Thank you very much.
Thank you. Good evening, everyone. Thank you, Albie, for inviting me to speak. Okay, so, okay, fine. This is just a brief overview of my talk. Okay, so what is Guillain-Barré syndrome? It's an immune-mediated acute polyradiculopathy, which means it affects multiple nerve roots and nerves. And it's actually an umbrella term for a group of heterogeneous disorders that share a common pathogenesis and have shared clinical features. Now, these disorders are many, and they can be divided into systemic variants and regional variants. For the purpose of this talk, I'm going to focus on classical GBS, otherwise known as acute inflammatory demyelinating polyneuropathy, or AIDP. You may see some other variants that are common in other areas of the world, but in South Africa and Africa, it's classical GBS. Okay, so it's the most common cause of acute flaccid paralysis, and the worldwide incidence is about 1 to 2 cases per 100,000 persons. And it can occur at any age, but the peak is between age 50 to 74, and our patient was 59, so he fits right in there. And also men are 1.5 times more likely to be affected, so also our patient fits in there as well. Most cases are sporadic, but they have been epidemics, and these are associated with outbreaks of bacterial enteritis caused by contaminated water. Okay, so 2/3 of patients have an infection in the preceding 4 weeks, usually a flu-like illness or gastroenteritis. And the identified organisms are Haemophilus influenza, varicella zoster, Zika virus, HIV, Campylobacter jejuni, CMV, EBV, Mycoplasma pneumonia. We've also seen it with COVID, and also in endemic areas with dengue and chikungunya. And there are also non-infective associations. And these are trauma, surgery, vaccines, immunosuppressive drugs, and autoimmune diseases. Okay, I just wanted to make note about GBS post-vaccination. It's actually very rare, with less than 1 per million vaccinations. And why the association was initially described was due to back in 1976, the H1N1 vaccine. There was like a cluster of GBS associated with that vaccine, and also the old brain-derived rabies vaccine. So it's more beneficial to vaccinate. It should not, stop patients from vaccinating. Right. Now, if you look at this map, it has data from centers that have reported cases of GBS. Unfortunately, in South Africa, we didn't put out any studies, but in Africa, you can see in Tanzania, there's an incidence of 0.83 and Libya 1.73. So in Africa, we didn't describe the type of GBS or the antecedent event. But if we look at North America, in Europe, in the Middle East and Oceania, the main GBS subtype is AIDP or classical GBS, and the antecedent event is usually the upper respiratory tract infection. Now, in South America, the antecedent event, the most common is actually Zika, and also in Mexico. And in Asia, you see a number of GBS subtypes. So AIDP, Miller-Fisher syndrome, and another subtype called AMAN, which is acute motor axonal neuropathy. Okay, and also in Asia, the common antecedent event was upper respiratory tract infection, but in Bangladesh, it was gastroenteritis. Okay, so there are main two subtypes pathologically. That's AIDP, which I'm speaking about, and then there's AMAN. So with AIDP, if you look at the nerve, there's an immune-mediated attack on the myelin components, and then you may get secondary axonal damage later. But with AMAN, you get primary axonal injury, and there's no substantial demyelination. AMAN, Campylobacter jejuni, is seen often to cause AMAN via molecular mimicry. Okay, the clinical features you may well know. So patients have progressive ascending weakness of arms and legs, and also absent or decreased tendon reflexes. So usually the weakness is symmetrical, and they have mild or absent sensory symptoms and signs. Cranial nerve involvement is common. So if you look at these patients, they have facial weakness. So does our patient. They have weak eye closure. They may also have autonomic dysfunction. Our patient also had that on arrival. He had tachycardia, elevated blood pressure. And then there's respiratory insufficiency also in our patient. Pain is also a prominent symptom, which can be muscular or radicular. And patients should not be progressing for more than 4 weeks. So then you'd have to think of something else. Okay. So there was an important study, the International Guillain-Barré Syndrome Outcome Study, which was published in 2017. And it looked at a large cohort of patients with GBS. And what it found is these patients progress and within 4 weeks, and then a plateau is reached. Plateau was reached within 2 weeks in 96% of patients, and within 4 weeks in 99% of patients. And it's followed by a spontaneous recovery. And there was cranial nerve involvement in 50% of patients, autonomic dysfunction in 25% of patients, and ventilator support was required in 19% of patients. Okay, so the investigations we need to confirm the diagnosis. Firstly, it's nerve conduction studies. So you can see basically what we do when we perform nerve conduction studies. So we record distally on the limb, and we apply two stimulus, proximally and distally. And then this is a typical wave that's we get as an output. So what we see with GBS is that the wave has increased distal latency, which means that the wave is delayed. The start of the wave is delayed. We see something called conduction blocks, where the second wave is less than 50% the size of the first wave. We see temporal dispersion, which basically the wave is flatter and spread over a bigger space. And we see slowing of nerve conduction velocities. There's also prolonged or absent F waves, and the sensory nerve conductions are also affected. And then we do a needle EMG, and it shows that there's active denervation in the muscle, and the patient shows something called reduced recruitment. Okay, the other investigation that should be done is a lumbar puncture, and the typical finding is that you have elevated protein. There may be increased white cell counts, but they should be less than 50. And if they're more than 50, you have to think about something else. Okay, so if after those investigations you're still unsure, you could go ahead and do an MRI spine with contrast, and it shows thickening and enhancement of nerve roots or the plexus, and you can see here that's thickening of the roots of the cauda equina, and they're also enhancing. Okay, so other disorders to consider in the differential are spinal cord disorders. So, for example, a transverse myelitis or a spinal cord injury. You can think about, is it another acute neuropathy, like with botulism, poisoning due to lead, arsenic, thallium, or pufferfish? Could it be Lyme disease, or could it be porphyria? And then you have to think, okay, we move on to, is it muscle? Could it be an acute myositis or periodic paralysis? Or could it be a neuromuscular disorder like myasthenia gravis? Or could it be something that's attacking the anterior horn cells like polio? So these are the main considerations. Okay, so how do we manage these patients? So firstly, the general care is to monitor their pulmonary function, and watch out for respiratory failure, to check for autonomic dysfunction. So basically, measure vitals and check their pupils, and for an ileus. We get a swallow assessment to check for swallowing dysfunction. And then they often have infections and pulmonary embolus. And I think our patient had he had a pneumonia as well when he came in, so that was treated. So the patients have facial weakness, so they can't close their eyes properly, and they can have corneal ulceration. So you want to prevent that. So it's eye patches and eye drops to keep the eyes moist. And then we prevent ulcers and contractures. So we get physiotherapy involved, we get regular turning, a ripple mattress. And if they have pain, we use opioids, we use gabapentin and carbamazepine. You need to consider when to admit to ICU. So definitely if you need ventilation. And then if someone has very rapid, progressive, severe weakness and autonomic dysfunction, you would admit them to ICU. And it's important to start rehabilitation early. Okay, so basically, let me move on to the next slide. So the the mainstay of treatment is with immunotherapy. Okay, so you can either choose between plasma exchange or intravenous immunoglobulin or polygam. That's what we use. And they're both equally effective. Okay, but it's up to the clinician. So I chose plasma exchange because polygam shouldn't really be used in the face of florid sepsis. And also, if someone has renal dysfunction, it's a contraindication to polygam. And important to note is that steroids are not beneficial and they could actually worsen GBS. So please don't give IV steroids. Okay. So, patients and their families, and also, other travel medicine, the part of the travel medicine team, they want to know what's the prognosis, So 10% of patients are disabled after a year, and 3 to 5% of patients demise. And death is usually due to pneumonia or pulmonary embolism or cardiac arrest due to the dysautonomia or acute respiratory distress syndrome. Each patient's recovery is variable. Okay, the speed of and degree of recovery is variable. And the most common residual deficits are weakness of the lower limbs, numbness of the feet, and the facial weakness. Now, there's a few adverse prognostic factors, and these are, if patients are elderly, if they had a rapid onset, if they were bedbound, like our patient, artificial ventilation, also our patient, if they have low amplitude unstimulable CMAPs, which is seen on the nerve conductions. Also, our patient had that. If there's axonal involvement, it's a poor prognostic factor. And if there's antecedent Campylobacter jejuni infection. Now, there's two prognostic models that we use, which is here. It's the modified Erasmus GBS outcome score. It predicts ambulation at 6 months. And then there's the Erasmus GBS respiratory insufficiency score, which predicts the need for ventilation. They basically here, but if you look at these tables, you look at, okay, so what are the predictors? So it's time from onset of weakness to hospital admissions. Facial or bulbar weakness, and then you have to calculate the MRC score, which I don't have on here. And then also age of onset. So our patient's, he's 59, so his score there is 0.5. Oh, sorry.
No, it is elsewhere, so it must just be here that it hasn't progressed.
Oh, yeah, it hasn't moved yet, sorry.
Yeah.
Okay. Oh, okay, sorry. And then diarrhea is here. And then it's the GBS disability score. So basically, the higher score you have, the more likely you are to be disabled at 6 months. And just to say that GBS can improve over 3 years. Okay. Patients may never get their reflexes back. So it's not something that we often, we need to monitor. And yeah, thank you. If you have any questions, please. Yeah.
How will the nursing care monitor be with that code?
No.
No, I mean, just the way-
I ordered
this.
I audited that hospital in November last year, and they've got an ICU. The place is overcrowded, and we had a bad experience with another patient that we only heard about later, a head injury, that was kept there for nearly a year, was then referred for speech therapy. But they insisted on an air ambulance. And I said, but that's nuts. If you only need speech therapy, why do you need an air ambulance? And I've got some pretty bad photos of the guy when he arrived here with 2 residual subdural fluid collections. He spent a year in a rehabilitation unit here, tied up in a wheelchair, still with a feeding peg in and with a tracheostomy. So that's why the decision here was quite easy. If he needs ventilation, he needs to get out.
Did they ventilate?
No, they didn't. They said he didn't need ventilation. When the team arrived, the ISOS team arrived, it was clear that he already aspirated, which the swallowing is part of the problem, we know. But that's where his pneumonia came from. He aspirated. So they kept on telling us that his vital signs are stable. But when he arrived at Sunninghill, he actually had one of these autonomic crises. So he probably had one or two before that as well. So the bottom line is that's probably not now the best hospital in Bamako, but it's got a long-standing reputation. It's got the contract with the airlines to take off sick patients, so they get them. There's one other hospital run by the Turkish, which is arguable. I wouldn't leave anybody there long-term anyway.
And just to let you know how the patient's doing, is that he's now breathing on his own. He has a tracheostomy, and he goes off the vent for about 8 hours at a time. So he has, so we're trying to wean off the vent. He has a peg for feeds. His power is 2 out of 5. Yeah, I mean it's not. So long term is he's going to need to move to a rehab center after he's off the ventilator completely. Yeah.
How many?
Well, he came out on the 27th of June, and so we're a month.
It's still on the first.
Yeah.
1st of July.
What do they do with rehab?
So he needs physio, occupational therapy, he needs psychology, social worker. But what do you know?
What does the physio do? Because I mean, so it's just passive physio.
Yes, passive
muscles and
passive.
I mean, he can't
Stretching.
Right.
Yeah. The other thing is that he's got profound neck flexion weakness, so he can't pick his head off the bed, and that's a clue actually to say this patient's going to get respiratory muscle weakness, because the diaphragm and the neck have the same C345, innervation. So I mean, if you have a patient and you want to say, okay, are they at risk of respiratory involvement as well? You can say, how's the neck? They say it's weak, then in trouble there.
It's a month.
Mm.
Has he reached the plateau? So
He's reached the plateau. He's not going to get worse. Yeah. He's not going to get, unless there's something else going on, he's not going to.
So you guys intubated? Yeah.
No. ISOS intubated.
Yeah.
That was another thing. We were told he's on 6 liters of oxygen a minute. That's quite a lot. But he's fine. He doesn't need ventilation. But then when they got there, they said they're not going to fly him unventilated. And we agreed with the diagnosis here, and he went on to tracheostomy.
So could you identify possible causes of organism? I saw that he tested positive for at least 3.
He did test
things.
positive for a few things, but I don't think that, any of them were actually active. I think they were previous infections.
Okay.
And
So
we
there's no
couldn't tell how long ago.
Yeah, so
But-
with him, he didn't have any, well, he says he was fine. He's speaking now, so when we speak at the trachea, his voice is beautiful, Yeah, he's speaking completely normally. Yeah.
So when the rehab here,
Not sure.
Well, that's one of the questions. So he's got to be stable enough to fly back, and his respiration's got to be good enough to fly back, because it's not going to be an air ambulance. It has to be commercial. It's going to be a long trip again. So he'll probably need a medical escort. The question is, how much rehab do we do here? And what are the rehab facilities like in Fiji that you send him back to? And the other question is, how long is the insurance going to pay for what? So those are all the things that are up in the air, and why Mr. Broomberg is sitting here with a beady eye watching all of us, looking for answers.
How many GBSs have you treated and what's the outcome generally?
So I've had some who were walked out of hospital. Yeah. And then I've had some who have been on the ventilator for like 3 months. So it's so variable. And I treat at least, I would say, 5 a year, especially around winter. Yeah.
So from a travel medicine point of view, is there anything special in Fiji that people need to be on the lookout?
No, but that's now why I'm feeling guilty that we haven't already submitted into Geocentre. Because I was like, well, it's not a sleeping sickness out of Zambia that we say, hey, it's just another. But if we report this, and the guys in Australia on Geosentinel are picking up a few more cases, or New Zealand, then we can say, hey, there's something going on in Fiji. And that's the whole purpose of Geosentinel, the beauty of it, is that we can pick up something that we wouldn't pick up on individual patients like this. So I'll send him in.
Haven't gone.
No, we don't. But if we say, hey, we've got a guy that came all the way from Fiji, and New Zealand says, hey, we've just had 5 admissions from Fiji in the last month as well, then the clinical network, the academic network can go and say, hang on, is there what's going on in Fiji? And then they'll start investigating on that side.
What's that COVID vaccination? Spaghetti.
I actually don't know.
He wouldn't have had one just out. We would have known because we saw his vaccine certificate, and he's pretty much up to date. I knew I was going to put it in, but he definitely had 3 rabies vaccines. He's had a Hep A, Hep B, a typhoid. He's had a yellow fever. I think he had a COVID, from what I can recall. I remember he did. Yeah, but it was 2-3 years ago.
I'm glad that you mentioned the very low risk post-vaccination, because it's very common at travel clinics that the nurse would phone us and say, there's somebody that said he recovered from Guillain-Barré 10 years ago. Can I give him vaccines? Now, and I don't know where I get this, but we've been saying if it's 10 years ago, of course, but we would be a bit careful for somebody that's recovered in the past 2 years about vaccination. So maybe we need to go and find out about.
And also GBS doesn't really, it's very rare. You unlucky if you have it twice. I mean,
once,
then you just have bad luck. Yeah.
If let's just say this is some CEO and they phone you from Addis or Dubai airport, and they saying, we need some advice, the oak's feeling a bit weak, would you encourage them to turn around? Or would you allow them to proceed, knowing that it may be Guillain-Barré, but it may also just be like a psychiatric problem?
You don't want either of them on an airliner.
But I'm saying that what would your advice be to that corporate? Now you've got the guy, he's phoning you, he's got an 8-hour layover, you've got a few hours to make a decision. He's feeling weak in his arms and his legs. It's getting a bit worse. Is it just because he's getting madly anxious, he's now going to this horrible line? Or is it
Dr. Gengan just said it doesn't happen twice in the same patient. So that's the first question. Have you had this before? That's a difficult one. I think I haven't had it with a Guillain-Barré, but I've had it with a possible deep vein thrombosis and a possible PE.
Yeah.
And the guy was sitting in Kinshasa, if I remember correctly. He was a geologist. And the luck was he was already sitting on the plane, and they were pulling the stairs away. So there wasn't much of a choice. But if he phoned me from the hotel, and this guy probably had a DVT and a pulmonary embolus from sitting in front of his computer writing a report for 3 days nonstop. He told me that. He was a thin, scrawny guy. And that guy who had, John, we called you about him, he had Mancinella perstans on his blood. He had malaria in Zambia, and they told him when he went back for his follow-up blood smear, they said, oh, by the way, you've got filariasis, and he was totally hysterical. And it was Mancinella, and I think you still said, you don't have to treat that. I said, you tell me I've got little worms wriggling around my bloodstream, and he said, don't have to treat that. So it's a very difficult one. If it was Addis,
But if it's Dubai,
If it's Dubai, it's
Right.
a Mediclinic, that's easy.
Yeah.
But if it's in a dodgy place, Addis is not a brilliant place from a medical point of view.
So I got a question from one of the audience from Beverly. Does anyone remember a patient called Pearl in Barra ICU with Guillain-Barré on the ventilator at the time? It was for more than a year. Not sure if she survived or not. But this was. Do you
Which
remember?
year?
that?
I was
don't
at Barra,
know
but I
now.
don't know which year.
Because I remember we had a patient like that they were in medical high care and she was on a ventilator for more than a year.
Because what happens then? I mean, the nerves recover. Sorry, Dr. Gengan, the nerves recover, but then your muscles are so wasted. So how do you get the muscles going again if there's
Yep. So when you lose your neurotrophic factors to the muscle, then you get muscle wasting. So as the nerves recover, then you get muscle back.
there's nothing?
Yeah.
Okay.
Yeah.
Right.
You can build muscle.
And the
I was
plasmapheresis?
just with plasmapheresis. I think when I saw him, he had 1 out of 5.
He's actually had 10.
10.
Yeah.
And so in retrospect, it didn't do a thing.
No.
Because if it works, it's quite dramatic, isn't it?
No, it can take a while.
Right.
Yeah.
And what are we freezing? What are we taking out?
Antibodies. So
Just
there's
general antibodies.
yeah, so they
Steroids, is that a common phenomenon with these demyelinating things?
no, actually.
It's like
No.
toxical.
So with the acute with GBS they don't respond, but with CIDP, that's they do. Yeah, exactly.
Anyone, what's going on there, that you're giving them antibodies for an antibody disease?
No. No.
I remember he was given steroids and
He was
Oh, okay.
given steroids, yeah. No.
before he left home, he said he was feet were tingling and he was struggling.
Mm.
Before he left home.
Mm.
That's the history I also got, that he told his wife his legs, he was just not feeling well.
Yeah, I said my legs are feeling funny. That's what I said.
But now that he can speak, has he got any story about a upset stomach or something?
Or a flu respiratory. But then he progressed from within less than 3 days to a hospital admission. I mean, that was very fast.
Mm.
So that's another poor.
It's a poor prognostic factor, yeah.
Alright.
Thank you very much.
Okay, thank you,
Just,
everybody.
we've got a last slide just for the audience to say thank you for Monica from Sanofi that has patiently sat here. She also brought us some nice things to eat. And just thank you very much for that support. And we've all heard now that vaccines are safer than getting the infections from the GBS point of view. So thank you very much.
Okay. Thank
Thanks,
you.
Dr. Gengan, for coming. Yep.
Thanks.
Thanks to
Thank you.
everybody online.
Thank
you.
everyone. We'll see you next month.
Bye.
Bye.
You mentioned the bus trips.
It'll be good to just put a hand up.